DMARD, disease-modifying antirheumatic drugs. It's a group of drugs that slow or stop immune system from destroying the joint. Rheumatoid arthritis is a chronic inflammatory disease that may result in significant disability. RA is systemic in nature and often affect joints in a symmetrical manner. It affects many systems. It may affect the heart, eyes, may affect vessels, and other systems. The primary symptoms of rheumatoid arthritis include joint pain or stiffness, weakness, and muscle ache. Joint deformity typically occurs late in disease progression, and also there are extra-articular manifestations of rheumatoid arthritis. During the treatment of rheumatoid arthritis, DMARDs are used. Welcome to SR Medicine. Don't forget to subscribe, like, notification button, share, and feel free to email me. How they work: they reduce the immune system's response from attacking erythematic tissues, targeting a specific part of the body's immune system response. They also work on immune system proteins. However, apart from treating rheumatoid arthritis, DMARDs may also be used for the treatment of other diseases like systemic sclerosis, inflammatory myositis, ankylosing spondylitis, rheumatoid vasculitis, psoriatic arthritis, uveitis, systemic lupus, erythematosus, inflammatory bowel disease, Crohn's disease, and ulcerative colitis, juvenile idiopathic arthritis, and also multiple sclerosis. However, methotrexate was first used for the treatment of some cancers. Classification of DMARDs: they are mainly categorized into two. There are those which are non-biologics. These are conventional, produced from chemicals like methotrexate, leflunomide, hydroxychloroquine, sulfasalazine, then azathioprine, minocycline, then there is also cyclosporine A and cyclophosphamide. We cannot forget mycophenolate. All these have the capacity to significantly alter the course of rheumatoid arthritis. Then the biologic are mainly their tumor necrosis factor, and also those which are non-tumor necrosis factor that inhibit proliferation of B cells and T cells. We shall also look at the genase kinase inhibitors. Biologic DMARDs are antibodies that are similar to those made in the body, but these antibodies created in the laboratories. Etanercept, infliximab, then adalimumab, golimumab, tolizumab. Those are the examples. Now to dive into more examples of the biologics: TNF alpha inhibitors, tumor necrosis factor inhibitors, the etanercept, infliximab, adalimumab, tolizumab, and also golimumab. Then the interleukin-1 inhibitors, the anakinra, interleukin-6 inhibitors, tocilizumab, then the B-cell inhibitors, the rituximab, the T-cell inhibitor like the abatacept, and also the genase kinase inhibitors, also known as biosimilars, and the examples tofacitinib and baricitinib. Let us dive into some of the effects of these non-biologics. Starting with methotrexate. This reduces inflammation and decreases joint damage. The side effects may include liver function problems. Therefore, regular blood tests are necessary. No alcohol use because of the increased risk of liver injury. With this combination, nausea, vomiting, thrombocytopenia, photosensitivity, chronic hepatotoxicity, stomatitis. Women should not become pregnant or breastfeed well on this medication. Women and men should stop methotrexate 1 to 3 months prior to attempting to conceive a child. Then another non-biologic, that is sulfasalazine. This one treats rheumatoid arthritis and arthritis which is associated with ankylosing spondylitis and inflammatory bowel disease. Now the reason as why I can be used to treat inflammatory bowel disease, sulfasalazine is a prodrug which is metabolized, broken down into alpha-pyridine to treat rheumatoid arthritis, and also broken down into 5-amino salicylic acid. This treats inflammatory bowel disease. It is a local inside, therefore people who are sensitive to aspirin, they are not given sulfasalazine. Side effects include changes in blood counts, nausea, vomiting, sensitivity to sunlight, skin rash. People who are allergic to sulfonamide medications such as sulfamethoxazole, they are not given sulfasalazine. Then periodic tests are recommended to monitor the blood count on regular basis. This drug is yellow-orange in color, therefore color changes in urine, tears, sweat develop an orange-tinge color which can stain clothes and contact lenses. Therefore, plenty of fluid are needed while taking sulfasalazine, and to avoid taking it on an empty stomach or with anti. Another example which is usually used, that is hydroxychloroquine, originally developed as a treatment for malaria. It also improves symptoms of arthritis. It is frequently used for treatment of systemic lupus erythematosus. Watch my video on SLE. Side effects of hydroxychloroquine include increased risk of damage to the retina of the eye. Therefore, current screening tests allow early detection of this toxicity and drug discontinuation prior to clinically apparent vision loss. GI complications, skin reactions. Then another drug, that is leflunomide. It inhibits production of inflammatory cells to reduce inflammation. Side effects include rash, temporary hair loss, abnormal liver function tests, anosmia, diarrhea, weight loss, and also abdominal pain. Neuropathy, nerve damage, and the GI complications accompanied with high blood pressure can occur. Therefore, women should not become pregnant while taking leflunomide or while it is still detected in their body. Thiopurine has been used in treatment of cancer, rheumatoid arthritis, systemic lupus erythematosus. Side effects include nausea, vomiting, decreased appetite, liver function abnormalities, low white blood cell count, and infection. It is usually taken by mouth once daily. Minocycline causes moderate reduction in rheumatoid arthritis progression compared with other agents. Side effects may include nausea, vomiting, hepatotoxicity. Then biologic DMARDs. Let us also dive into their mode of action and side effects. These out a specific step in the pathogenesis of the inflammatory response, which is associated with rheumatoid arthritis. These agents inhibit pro-inflammatory cytokines such as the tumor necrosis factor, interleukin molecules, and among other mechanisms, as we are going to see. Tumor necrosis factor alpha inhibitors. It's a pleiotropic cytokine that plays a key role in the inflammatory process of rheumatoid arthritis. The TNF inhibitors work by binding to TNF alpha and blocking its activity on cell surface receptors. Examples are etanercept, infliximab, adalimumab, golimumab, tolizumab. A combination of TNF inhibitors with methotrexate improves the response. Precaution during the use of TNF inhibitors. Because these agents modulate immune system response, serious infections are also a concern. Therefore, vaccines should be administered before anti-TNF agent initiation. Patients should also be screened for tuberculosis. Live vaccine should not be administered during the treatment. Tumor necrosis factor inhibitors may induce or exacerbate multiple sclerosis and reactive hepatitis B and C infections, heart failure exacerbation, and increased risk of cancer. Number one is etanercept. It is a dimeric fusion protein that consists of an extra portion of a human P75 TNF receptor linked to an FC portion of the human IgG. Etanercept is self-administered by subcutaneous injection and can be used as either a monotherapy or combination with methotrexate. It rapidly decreases symptoms and joint damage, usually after 12 months of the therapy. Infliximab is a chimeric antibody that combines murine and human IgG. Infliximab with methotrexate reduce signs and symptoms, stop progressions of joint damage, improve physical function in patients with moderate to severe rheumatoid arthritis. Methotrexate is administered concomitantly with the infliximab to prevent formation of antibodies to this foreign protein. In previous treatment, during treatment of rheumatoid arthritis, was treated depending on its severity. Mild, moderate, and also severe. However, these days, aggression from the beginning to achieve remission. Therefore, early diagnosis, early aggressive treatment to remission. However, it's always good to start with insights to bridge the gap because DMARDs take weeks to months to start working. Infliximab is administered by intravenous infusion. Adalimumab is a fully human monoclonal antibody specific to TNF-alpha and is produced using recombinant DNA technology. Adalimumab is self-administered as subcutaneous injection and is approved for use as monotherapy or in combination with methotrexate. Golimumab, this one is a fully human anti-TNF IgG monoclonal antibody produced using recombinant DNA technology. It binds to both soluble and transmembrane TNF, which allows for both receptor binding and inhibition of cytokine activity. Golimumab is also indicated for use in combination with methotrexate. Tolizumab is a pegylated Fab fragment of humanized anti-TNF monoclonal antibody and can be administered with or without methotrexate. Other biologic DMARDs, co-stimulation modulators, are abatacept. Now, to become activated, T cells, specifically the CD20 receptor, require co-stimulation with CD8, 86 on antigen-presenting cells, the APCs. What happens? Abatacept inhibits inflammation, which is associated with rheumatoid arthritis, by preventing the interaction between the APCs and T cells. It is both intravenous and subcutaneous. Can be combined with non-biologic agents such as methotrexate, but not with the biologic agents, especially the anti-TNF agents. It is not combined with other biologic DMARDs. Common adverse effects with abatacept: infections, infusion, the invets, then headache and dizziness. Then we have the anti-CD20 agents, rituximab. It is an engineered chimeric monoclonal antibody to deeply peripheral B cells. Now, the role of B cells in inflammation process of RA includes production of pro-inflammatory cytokines, the TNF-alpha, interleukin-1 and 6, and disrupting antigen presentation by T cells. Therefore, your plasma cells, which are derived from B cells, produce antibodies, e.g. the rheumatoid factor, that promote the autoimmune process of rheumatoid arthritis. Therefore, with B cell depletion, rituximab theoretically decreases the concentration of circulating Ig in the body. It has also numerous side effects: pruritus, fever, rash, chills, hypertension, hypotension. Interleukin-6 receptor antagonist, tocilizumab. This is a humanized monoclonal antibody that binds to interleukin-6 and inhibits its inflammatory effect. It is an intravenous with adverse effects which include increased liver enzymes, increased cholesterol, decreased neutrophil, and platelet count. Tocilizumab induces cytochrome P450 and may decrease the serum concentration of drug metabolized by this enzyme. Therefore, tocilizumab is good for patients who have not responded to at least one DMARD. It can be used without concomitant methotrexate. It is an alternative for patients who cannot tolerate methotrexate, for whom methotrexate use is inappropriate. Interleukin-6 antagonist, that is anakinra. Interleukin-1 is a cytokine that is produced in response to inflammation and contributes to cartilage degradation and bone reabsorption. Anakinra may be used as a monotherapy or in combination with other DMARDs, with the exception of anti-TNF drug. It is good for patients whose disease has failed to respond to other DMARDs. It is subcutaneous. Then lastly, we have the genus kinase enzyme inhibitors. The genus kinase, this is a family of intracellular non-receptor tyrosine kinases that transduce cytokine-mediated signals via the JAK-STAT pathway. The good example, we have tofacitinib, which is a member of the university class of agents. It can be used both as monotherapy and in combination with other DMARDs such as methotrexate, but not with other biological agents. Adverse effect: headache, then it may cause hypertension, diarrhea, upper respiratory infection. Tofacitinib may contribute to neutropenia and may also increase liver enzymes and lipid parameters. These DMARDs take weeks to months to work. Therefore, during that period, NSAIDs may be used. Lastly, rules for treatment of rheumatoid arthritis: do not combine more than one medication. It is possible for synthetic DMARD with a biological DMARD. Never combine more than one biological DMARD. Biological DMARD cause infections. In such a case, temporarily withdraw. Early treatment: use methotrexate. Combination therapy is better than monotherapy. Avoid the chronic use of NSAID. Glucocorticoids can act as a bridge until DMARDs kick into gear. Never use NSAIDs and steroids as a monotherapy. Vaccinate before immunosuppressants. Thank you for watching. Don't forget to subscribe to SR Medicine. Email me as I make more content. Thank you.